I'll introduce myself. I'm Steve Pilley, and I'm a UCL academic who know most people here, but I spent about 5 years here running the Low Intensity IACT course, in fact, so I'm very familiar with the environment, much nicer, I can tell you folks, than UCL teaching space, so I rather like coming back. But the reason I'm here is I had a conversation some months ago with Miranda about where we were getting or not getting with clinical guidelines. And I should say that the National Collaborating Centre for Mental Health is the group that produces clinical guidelines on behalf of NICE. So for the past 12 years, I have, along with a chap called Tim Kendall from the Royal College of Psychiatrists, been producing clinical guidelines, which, as you will or should know, set the standards for healthcare in the NHS. And the stuff we do sets the standards for healthcare in mental health, essentially. And we produced, I will not going to go into the background. The Collaborating Centre is a website, you can look on it. But just the final thing to about background is we produce now pretty near 30 guidelines. So it's the biggest mental health guideline programme there is anywhere in the world. And it's a decent quality one. We get reasonably good reviews for what we do, both nationally and internationally. That's the general introduction. The specifics are that we cover mental health very broadly defined, we cover neurodevelopmental disorders, for example, autism and ADHD. We cover dementia, we cover both common and severe serious mental disorders, and we cover adults and children. But one reason that you might not be desperately familiar with clinical guidelines is we say relatively little about children. Some of our guidelines, for example, a guideline on OCD has very little, doesn't cover children at all. The guideline on PTSD does. Eating disorder does. And then we have specific pieces of guidance, for example, conduct disorder, which I'll say a little bit more about in time, and childhood depression, or treatments for childhood autism, are very specifically focused on children. And the point of being here today isn't for me to particularly lecture you, talk to you about child interventions, but hopefully to set up a bit of a discussion of, if I put it in a slightly polemical way, why is it that the evidence for childhood mental disorders, the evidence for their effective treatment, is so bad? Because, folks, compared to the adult data, it's pretty bad. And I'm kind of interested in sort of understanding a bit more why that is, because I'll tell you some of the reasons why I think that is now. Perhaps it's probably easiest to go on to the first slide. So some of the issues that I just want to kind of either highlight to talk about are what I've called, first of all, the obvious. I mean, 50% or more of adult disorders have their origins in childhood. Social anxiety disorder, typical age of onset around 12, 14, eating disorders 14, 15, antisocial personality disorder. You can't actually have a diagnosis of antisocial personality disorder unless you've had conduct disorder in childhood or adolescence. And so it seems to me, as a kind of occasional adult clinician, that actually, I could be working a lot less hard if you folks, and I'm referring to you in the general child clinicians in a very general sense of that word, if you folks were actually able to do a better job. And so it's a kind of obvious point. The second point is, I want to just talk a little about the comparison. I've just got a couple of slides which are just really lists more than anything. There's a very broad range now of adult interventions, and I'm going to concentrate today just on psychological interventions. I'm not going to say anything about pharmacological interventions really, or about service style interventions. So it's very much focused on psychological interventions. And that contrasts really rather significantly with the very narrow evidence base, as I would see it, for child interventions. And I want to try and finish up with some discussion of why that is. I called them case studies. This is a total overstatement of what they are. They're just a list of a few effects. But I just want to contrast two recent guidelines, two guidelines that are in fact coming out this year, a guideline that we've just completed on conduct disorders and a guideline on social anxiety disorder. And then I want to talk about with you a little bit about what the solutions might be to those problems. So that's a bit of the structure of it. And I want to just start with a bit about the origins of social anxiety disorders. 50% plus of adult disorders have their origins in childhood. They start and they continue through life. The course of why this is important, apart from why it gives a real good opportunity to intervene earlier, why it's important is many of those disorders that start in childhood and adolescence have a more chronic course with early onset. And that's certainly true of depression. Depression that first presents in adolescence tends to have a more chronic course, tends to be more debilitating, tends to be harder to treat. I mean, conduct disorders, you'll know better than I, gets itself divided into early and late onset, but early and late onset or not, conduct disorder has a spectacularly bad long-term outcome in terms of physical mortality and morbidity, in terms of cost, in terms of educational achievement, in terms of comorbidity. It's not good news. So being able to intervene early would seem to me to make a lot of sense. My German failed me, I'll come to that in a minute, but the impact of mental health can be quite wide-ranging. As you'll know, comorbidity is a sort of norm in childhood disorders, but the effects are quite broad. So, for example, if you just look at social anxiety disorder, where diagnosis of social anxiety was made at 12, it's Bodas. I'll get you the proper reference. It's a recent paper from Uli Wittgen's group in Germany. Rather very good, high-quality epidemiological study looking at the long-term course of social anxiety disorder, and the impact is quite wide-ranging. So it's typically said that social anxiety disorder starts around 12, 14, 15, and it can have a quite chronic course. The oft-quoted figures are about 60% of people will still have the disorder. Actually, in this rather well-conducted study, it looks like it's much smaller than that. It may be about 25, 26. It's only about 15, 20% of people. But actually, even if people haven't got social anxiety disorder, about 60% have significant symptomatology that's causing them difficulty. So even if the original disorder ain't there in a narrow diagnostic sense, the consequences of it can be seen. And the impairments in functioning that are associated with that long-term disorder are again significant. Education and employment, and you can look at conduct disorder and social anxiety disorder. As you'll see, I'm a bit fixed on these at the moment, but there's a study. This is not Robert Goodman, I should say. This is I think Alan or Andrew Goodman, who's an economist from the Institute of Fiscal Studies down the road, a sort of UCL offshoot. And conduct disorder, the presence of a mental disorder in childhood is associated with a near 30% reduction in earnings at age 50 compared to a comparable group. So there are major impacts on your life of childhood mental health disorder. And some of the other things that we just need to throw in here are not just the issues about treatment, but how good are we at recognising them? And percentage has not appeared there, but a lot of adolescent depression is missed. It's just not picked up. So we're not picking up disorders. When we're picking them up, we are at danger of misdiagnosing them for all sorts of ways. So one example, as you might know, this is bipolar disorder, not borderline personality disorder, but bipolar disorder's age of onset is mid-late teens. It's quite early onset, perhaps a bit earlier for the major mental disorders, probably earlier than on average than schizophrenia. But a large majority of the first presentations of bipolar disorder are depression. And the estimate is maybe up to 20% of people, including adolescents, presenting with depression may indeed have bipolar disorder. It's missed. And, apart from the fact that that denies the opportunity to intervene early, which it may, there's also additional risks in there, as you may know, as a subject to some debate, but about maybe up to 6% of people with bipolar disorder who are placed on an antidepressant without an anti-manic cover, say an antipsychotic or lithium, could switch into a manic or hypomanic episode. So misdiagnosis not only might have long-term consequences, it can have short-term bad consequences as well. And one thing we learned on the, or I learned as a non-child clinician on the conduct disorder guideline, is it might be the commonest mental disorder of child and adolescent, but it's certainly not the most often treated. And I don't know how many of you are working in CAM services, but Stephen Scott, who chaired our group, was very clear that actually getting, knowing the disorders there, identifying it was one battle. Actually getting CAM services to take some of these young people on was another battle. And we had a very impressive head teacher on our group, very, kind of mental health professionals in the family, so to speak, very keen and very committed. Hadn't heard of conduct disorder. Just thought these were naughty kids who were just needed sorting out in a nice way, as opposed to the ways other people might want to sort conduct disorder kids out. So that's something of the kind of background which makes you think, actually, this is important. Now, what I've got here, which if you brought your binoculars along, you will be able to read. But it's not so much the detail of the reading, it's more the density of the text that I want to draw your attention to. So this is taken from guidance that we've produced variously over time for NICE, for the adult IAP program. And it's in that stepped care model that some of you might be familiar with from the IAP world, of starting at step 1, which is essentially recognition and assessment, usually in primary care setting. The step 2, which is this focus on low intensity, brief, structured interventions, which are really much more about facilitating people's ability to manage and treat their own difficulties rather than offering them direct treatment. And then what we would see as a psychological treatments here. And what you can see is a wide range of treatments here. So just pick one at the top there, depression. We have within the NICE kind of family, we have 1, 2, 3, 4, 5, 6 psychological interventions, of which, at least for 4 of them, there's a pretty solid evidence base. The evidence base for short-term psychodynamic therapy and counselling is a little weaker, really, but nevertheless, there's some choice there of treatments that work. And you could look at eating disorders, CBT, IPT, family intervention. So there's a substantial body of evidence there. It gives some choice. We're not very evidence savvy about which one you might choose, but there's a substantial body of evidence there. So what I did for today is I just took the table and I populated it with what we know about child interventions. And I should also say, I've been very generous here. So, and the generosity is indicated by the asterisk, which you probably can't see. There'll be a little blob here. But as you can see, we don't fill the boxes, whereas they were a bit crammed, a bit overcrowded. And actually I filled this box, so to speak, by putting in GAD and CBT, panic disorder CBT, OCD CBT, because I know there's some studies out there that, but we haven't covered them in the NICE guidance. If I limited this to NICE guidance alone, that box would be even less well populated. And even down at the bottom here, what we know, for example, and I won't say much more about this today, is we're pretty good, say when it comes to simple case identification questions for depression. So the so-called Hooley questions, low mood and loss of interest in the last month, are quite good predictors of good sensitivity and specificity, rather, for identifying depression and prompting cost-effective further inquiry. We struggle on that front again in the child world. So that's partly what precipitated my conversation with Miranda, that we got some pretty empty boxes there, and what I'd like to, just for my own education really, what I'd like to try and do this afternoon is discover a little bit about why that is. Now, I've got up here some reasons why I think that might be, and what I want to do is just go through them, and perhaps if you just hold them in mind over the next 30-40 minutes, and we might want to come back to them. So, the obvious place to start with this is to say that the difficulty with the lack of evidence is just a resource issue. Funding bodies, the MRC, the National Institute of Health Research, the Wellcome, just haven't put money into treating childhood mental disease, into evaluation and development of treatment of childhood mental disorders, and I'm sure that's true. I think, though, there are a number of other issues that we need to think about. We need to think about capacity. And by this I mean, what's the capacity to develop and evaluate new treatments in the child mental health world, here in the UK, in the US, in Europe, in other parts of, Australasia, South America. And I think it's limited. I think, as a non-child expert, I think I know half of the world's treatment developers for child mental disorders already, really. I've, quite a series of quite chatty emails with Phil Kendall over the last few months. There is not a lot going on compared to what's going on here. I mean, I used to, it's a bit like, I used to sit on one of the BABCP kind of management governance groups many years ago, and I looked at the membership. It's the British Association of BCP, so British Council of Psychotherapy, and if you got out a very long rope, it was about 4 miles long, and you stuck it somewhere in that garden and then create a radius, you'd take care of about 79 or 80% of psychotherapists in Britain. And it's not that dissimilar. There's probably a couple of spots here around UCL, up in Manchester, down in Sussex. You'd be taking care of a large group of people actually doing research in this country. Reading, another one. So it's a pretty small bunch. But then there's a question, which I don't know if I'm right in this is a speculation. There's a question of what the focus of interest is in clinical academic settings in child mental health. And my, slightly ill-informed, you might argue, or speculation, opinion, is that actually there's a much stronger premium, much stronger interest in what I call developmental psychopathology, understanding something, of course, the nature of the stuff that Pascoe, Eamon, Peter, people around here have done, very effective, very interesting work, but it's not, although Peter shifted a bit that way significantly that way of recent years, it's actually not been something that I think the field has particularly concentrated on. Now, am I right in that speculation, do you think? Am I doing a disservice to my colleagues working in the child mental health field? Or is it that there's almost like a bit of a premium in this kind of focus on developmental psychopathology? Any views on that? Am I right, or you don't wish to cast aspersions upon your colleagues? You're not sure? Okay, well, mull it over. Tell me if you think I'm right later. It's then another problem, which is, I think, about the history of treatment provision, in psychological treatment provision, at least in child mental health services. So when I just completed my training, which is very many years ago, it's just short of 33 years ago, I think, yeah, sadly, long time ago, I completed my training. And at that point, child mental health services were very much dominated by the psychodynamic model. That's most of what the treatment was. Now, it seems to me, as an occasional kind of interloper into the world of child mental health, that's changed. It's now much more a systemic model that's in there. Is that correct?
Certainly shifted away a lot from the psychodynamic model. I think CBT is also increasingly dominant.
CBT is in the last, what I'd say, 4 or 5 years. I think CBT's got a bit of a handle. But I think certainly, you know, I do a bit of my clinical work locally, and my contact with some of my local CAM services, I've had a bit more recently than I've had it for many years. It's very much, I think, a systemic model is probably a prominent model. And the point of putting that up is to say they're actually, although in the adult world, and it's interesting, the evidence base for both of those approaches is relatively weak. In the adult world, actually short-term psychodynamic psychotherapy, particularly depression, doesn't do badly in terms of available trials. Systemic therapy does really rather badly. In the child world, they're both in pretty good company. You know, most interventions do badly, but there is just a bit of a question in my mind that at the clinical level, neither of those two approaches, I think, have had a very strong tradition of evaluation. And I just think there might just be a clinical issue that's kind of held back evaluation. And that's changing, of course, but I think it has been a factor. And then another factor, which is a bit of a kind of rather vague term there, models of disorder. But I think there's something about people's conceptualization of, and this is anecdote here, this was my talking with colleagues both at UCL and in other services, that the kind of comorbidities which are omnipresent often in childhood disorders, the complexity of it, the interaction with social and family settings has made people think hard about the value of specific interventions. It doesn't sometimes fit as well as it might do in the adult world, where you can sort of extract an adult from the social context, from the family context, and get on and treat the problem. Now, it may sometimes often be a little optimistic or narrow-minded, but you can do that. But I think there's been a view in which it's been very difficult to separate childhood disorders from that broader family setting. And I just wonder if that's also been another factor that might just have impaired development. So that's my speculative list, really. There are 5 of them. Anything else that you might want to add, folks? Anything else that you think has kind of held back the field? Because go on. Yeah.
I think just you did talk about funding, but that might have to do something with medication, because it's not as obvious that medication is given to children, and I think obviously that the medical world does drive lots of the research.
Yeah.
And then all the non-medical treatments then say, but hello, we're here, so they do treatment justified that medical model, and I just wonder whether that could be one of the factors.
It's possible. I mean, the fact is that probably the best treatment you've got in child mental disorders is methylphenidate. You know, if you just look at the evidence base for it, it's as good as you've got, I think, if you just want to, well, actually, hold on to conduct disorder, I say that, but I think you've got a good evidence with. But interestingly, of course, you know, in adult mental health, that's the same issue. You know, the point that kind of, I think in Britain would be much more fortunate. So if you look about, which I know quite a bit more about, if you look at the development of CBT, so if you look at the development of CBT treatments for anxiety disorders, people like David Clark, Anka Ehlers, Paul Sarkoskis and others, they have over the last 20, 30 years, Chris Fairbairn, developed a series of interventions that I think have produced important and valuable shifts in outcomes. They've done a good job. Treatments are better now than so. When I trained 33 years ago, treatment for anxiety disorders was exposure, relaxation, and something I've forgotten. But you know, it was pretty simple stuff. And you got, you know, PTSD didn't exist as a diagnosis when I first trained. So, but what Clark and et al. Have done here about that, it's very interesting to contrast that with the United States. So if you talk to Steve Holland, who's Tim Beck's kind of anointed successor in the States, he spent 30 years of his life in a battle to convince people, insurance companies, not least among them in the US, that CBT is as good as antidepressants. And that's all they've done. And so it's very interesting. You look at the effect sizes, say, for PTSD, and the developments actually has seen over the last 20 years a significant increase in effect sizes. People got better at delivering and developing those treatments. if you look at the treatments, for example, for depression, haven't really shifted at all. In fact, you know, the first trial was the best trial, and nobody's ever approached Roche et al. in 30 or more years. So, and that's, I think, because the focus in the US was trying to prove equivalence to antidepressants, and that was all, and very little evidence was spent on trying to do that. In fact, you know, I have quite a lot of contact with Steve Holland, and his current thing is, can he try and do for depression treatments what Clark et al. Have done for anxiety treatment? So, you sort of, there's a bit in what you say, but I think if you look at what's been done in the UK, what the Wellcome in particular in funding, you know, Sarkoskis, Clark, Ehlers, Fairbairn and others, what they've done is they've really developed adult disorders. So medication, a bit of an issue, and curious, my experience when I used to run the mental health service in Islington some years ago, my big battle was persuading colleagues in CAM services to prescribe antipsychotics for psychotic young people. They were very reluctant to use medication, where I was thinking, gosh, you know, I thought this would be worth a try. But anyway, look, these are some of the reasons. So drugs and might get in the way is one option. Any others that you think? Go on.
I think I don't know, maybe just the widening the issue myself, but I think that the groups or patients or the children we are talking about may not be homogeneous.
Yeah.
It's kind of a heterogeneous group with all sorts of different issues, and they're affected by systemic reasons and another. So, but there is a push in the real world to make a diagnosis for a child. Yeah. Some people believe, some people don't. But you know, then you can develop some interventions, and you can negotiate with the parents and the children what intervention they will choose. So the starting point is actually making a diagnosis, as it were. Whereas actually, it's not terribly easy to make a diagnosis for a child, you know, until you know the child really well. Or sometimes it's not possible to make a diagnosis, which is related to the validity of the diagnosis at times. So I don't know, when we are talking about child with a depression, are we talking about the same child, you know, or a child with a different, you know, reason or different issues?
No, I think that's a good point. And in a sense, I was half getting at that with models of disorder, but I don't think I quite captured it properly. I think that is right. I'm not sure, and I've got a couple of slides to have raise the issues about it. I'm not sure it's all that, you know, I'm not sure it's quite right, but I think you are absolutely right that I think from my contact with cancers, that is a significant issue. Yeah, go on.
I wonder if, kind of two things, but from having worked in a child clinical mental health research setting in a university, firstly, it is very difficult to get research funding for clinical studies as opposed to neurodevelopmental studies. So the universities put more resources into those. But it's also, I think, an issue of it's more an issue of engagement of actual research participants, because in an adult mental health study, you've got an adult with a mental health problem to engage to participate in your research. But in a child mental health one, you've got a parent and a child, both of them you have to engage and agree. And then you've also got the added effects of, because if there's quite a lot of evidence that I've come across, like if you make a lot of progress with a child in therapy and then the parent is not on board, there's a kind of regression of the therapy, and there's all the sort of things that might actually be weakening the studies that are taking place as well, possibly.
Okay, where were you working before?
Reading.
Reading. Do you know, I kind of thought that working at Reading actually would be smart and get you working there. However, apropos of what you're just saying there, I did have a quite interesting conversation with Kathy Cresswell, formerly of this parish, now at Reading.
Yeah.
And she said that when they set up that university-based anxiety clinic, they were told, oh, you'll never get patients. And what Kathy now tells me, they've got plenty of patients.
Yeah, they get referrals via the NHS though, and I think that I think it's a unique, because I wasn't working in the Winnicott unit, I was working outside of the unit, and I was recruiting my own parents and children to take part in clinical research, and it was like squeezing blood from a stone, because they had the referral routes and the psychologists, and they were offering treatments. And I think it's also, parents are kind of like, you're going to try out an experimental treatment on my child, no thanks. It's a bit like, so I think Kathy's done amazingly to do what she's done, but I do think it's difficult.
Okay, now hold on to that one, folks, because I think there's a question there to ask, how much that is a professional attitude issue and how much it's a parental attitude issue. I think what you're saying, the facts, I wouldn't dispute, but maybe the origin of it. Anyway, anything else on that? Is that kind of going in kind of the right direction, raising some issues? Okay, now, this is just a couple of slides. I've been lazy and I've borrowed from elsewhere, which is one of the common other problems that crop up. Well, they're my slides, but you know, they're adult slides, which is why I've been a bit lazy. There's this issue as well about, you know, does results, just a couple of issues I don't want to deal with, do results from RCTs generalise? Is it that a bit, you know, could be interpreted, you weren't saying it, but it could be interpreted, you know, Cresswell, she just slices out a really nice bunch of people with high functioning, well-meaning and dedicated parents who deliver the goods. And that's often a criticism of randomised controlled trials, of the sort of stuff we base the NICE data on. And they don't generalise, and that what CAMS clinicians are, they're just wise. They've wised up to the RCT trickery, and actually, you know, life's a lot more difficult in clinics than in the real world. Now, it's quite interesting. I've just got a series of studies, and I apologise, these are adult studies. I would argue that it generalises quite nicely to child studies, but we're going to come back to that problem and we can debate it then. You know, actually, if you look, it says RCT stuff doesn't generalise. However, if you look at, there's a review now from almost 20 years ago that was done by Shadish et al., often quoted, and what that shows that actually, if you look at clinically representative populations, this is a meta-analysis, the effects really look rather similar. It is the case that you look like you're getting a similar effect, really. And there are a series of studies across some common mental disorders here over the last 20 years or so, where people have taken routine unselected populations, just gone into a clinic, they've selected people, they've given the treatment in the trial, and they've basically replicated the effect sizes. So it looks like you can do it. And my favourite, in a sense, study I quite often like to quote is a study from Edna Foe's group in Philadelphia, where they didn't just take clinically representative populations, they actually looked at all those people who'd been rejected for the clinical trials that Foe was doing. She does psychological treatments of exposure. And Franklin is the lead author on that, paper in JCP now, 15 years ago. They looked at it and they provided exactly the same treatment to the people who'd been rejected because they had comorbidities, they were on drugs, they'd failed previous treatments, all the reasons why people never get into clinical trials. And so the question for you is, because I haven't got it up there actually, what was the effect size? How did the effect size, by what order of magnitude did it differ from what Foe would find in their standard trials? Any estimates of what that might be?
Bigger effect size because you'd have more regression to the mean with more severe problems.
That is statistically quite sophisticated, and indeed that is absolutely right. But whether it was all regression to the mean or not, I'm not quite sure. But they did in fact show a more significant improvement in that group. And these are people who reject because they weren't going to get better. Because when you do a trial, you want to pick your winners. However, the thing to say about all of these, and this relates, I think, to the key point I want to just make here, is you actually only got that improvement if you use the same treatment with appropriately trained therapists. And so the point I'm making here is often the degradation in effect, I think, is as much a therapist effect as it is a treatment effect. So, but that's just to say that, things can generalise. And then the other problem, which is a significant problem, absolutely so, in child mental health disorders, is that comorbidities, people with comorbidities are excluded from randomised controlled trials. And they're not really. I mean, if the bulk of this data that's in our NICE guidelines, the bulk of that data is taken from the US. And I don't know if people know, do people know Jacques Barber? Well, Jacques Barber at one conference I was at 2-3 years ago addressed this point and said very clearly, look, if you look at the population that come into psychological treatment trials in the US, they are a significantly comorbid group. In that they tend to be unemployed, they tend to be poorer, they tend to have poorer physical health, they tend to have lower education. And that's because they're not insured. and this is their way of getting treatment. If you're insured, you can get treatment courtesy of your third-party insurer. So you get a slightly select and more disadvantaged group coming in. And, you know, if I just list there eating disorders, PTSD, drug misuse, conduct disorder, ASP, you know, the comorbidity is the norm. What's the overlap between conduct disorder and ASPD? Is it 60 or 80%? And conduct disorder and ADHD, sorry, is it 60% comorbidity? It's very high. It's very high. PTSD, 40% of people with PTSD and 40% of people in the trials would meet diagnostic criteria for depression. So comorbidity is the norm. Actually, if you look at it, for example, you find that you'll get significant reductions in depression by just treating the PTSD. So much of that depressive disorder would remit from the effective treatment of PTSD. So comorbidity doesn't, at least in the adult literature, exclude effective treatments. Same is true of eating disorders. And you can get some quite impressive results with rather simple interventions, for example in drug misuse, ADHD and conduct disorder. It might mean that you have to carefully select the intervention. You may need to extend the duration of the intervention. And I'll just show you just a slide here. This is a forest plot, for those of you familiar with them. And this is just the impact of contingency management, just offering a simple incentive, in this case probably $5, for turning up for a negative drug screen to a highly comorbid, chaotic group of people. And as you can see, the relative risk there was 3.7, which is pretty impressive. I can't resist telling you that we've just completed a largish trial of contingency management to support uptake of hepatitis B vaccination in an opiate intravenous drug using population. And you're going to get this right again, but I'm going to ask you to guess what you think the odds ratio for that was. This is offering 3 £10 Sainsbury's or Morrison's vouchers for pitching up to get your Hep B vaccination, which not having and getting Hep B confers a 10% mortality rate, as well as all the other people you might infect and the bad down. So it's a significantly dangerous disorder to just virus to be carrying around. Any idea what the odds ratio was there? 18.5. Staggeringly large. And so all I'm saying here is, here's a simple intervention in a very complex population that produces massive change, and the actual absolute figures were less than 5% in the control arm, and in two experimental arms, 1% each side of 50%. So a massive difference in things for simple interventions in very complicated people. Now, I want now to just go on to just look in detail about what we've said recently about a couple of childhood disorders. And this is the good news story. So this is the most common presenting mental health disorder in childhood. It's one associated with really very poor long-term outcomes. It's one associated with high cost. And it's one where, if I'm to believe Steve and Peter and others who work in these services, it's one where it's actually quite difficult to access the treatments. But if I just run through it, if you look at school-based, these are kind of selective prevention interventions where you're offering a school-based social and learning program for children at risk. And risk can be identified by parental vulnerabilities, by living in a poor neighbourhood, by belonging to a certain socio-economic group. And there are clear benefits of effects specifically on antisocial behaviour from those interventions. So the kind of social and emotional learning, somewhat more concentrated and intensive often than you see in the UK, those produce benefits. You're probably all very familiar with parent training, triple P, Incredible Years, Saunders, Webster, Stratton et al., and a variety of variants of this, group-based, standard parent training, group-based, focused particularly on fostering, individually based parent training for those parents in difficulties engaging with the program, all associated with significant cost-effective benefits for intervention. Multisystemic therapy, Slightly tricky one here. The data looks very nice, but it's almost entirely a US data set. And there is a bit of a question. We have a trial, as you may know, running at the moment, trying to address this issue. But again, in a very difficult group of people with potentially rather poor prognosis, it looks rather good. And then we've got group-based social and cognitive problem solving, CBT, basically, again, for kind of those, I think it's, what is it, 7 to 14-year-olds. And these are for younger children, these again are for younger children, these are for teens. There's some gaps in the evidence, but it's probably as impressive a data set for a set of psychological interventions as we've looked at. I can't, maybe CBT and depression kind of gets near to it, but in the adult world, I can't think of a database that is much better than that. It's a pretty impressive data set, but it's about the only one you've got. And then to look at another one, it gets much thinner, doesn't it, really? So, and this is why, there's a little less data, there's one I just want to say a little bit more about. So this is a guideline. I shouldn't really be showing you this slide because the guideline only just got signed off yesterday by NICE, and it will be out for a couple of months. But we looked at the adult data, psychological interventions. I'll say a little bit about that at the end. And then we looked at the childhood interventions for social anxiety disorder. And if you look at Miranda's data on early child IAPT, social anxiety disorder is just picked by depression as the most commonly presenting problem to CAMS services or to the CAMS IAPT service. So this is a common problem. And we know that its impact, for example, on schooling, on commodities are in there. Now, the preferred treatments have been the kind of coping CAT, the non-specific anxiety disorder-based treatments. And we really didn't look at those because we were not convinced that they showed very much and we weren't that interested. But we did look generally at them. And you're looking at there in individual CBT, for example, not focused specifically on social anxiety disorder, of an effect size of about 0.15. Now that's even smaller than small. And it's not, for what it matters, it crosses a line of no effect. But it looks like kids with social anxiety disorder don't do particularly well. In fact, they do worse than children with other forms of anxiety disorder. You then look at group and individual CBT with possible parental involvement for younger children, and there your standard mean difference creeps up to a sort of medium effect size. But it's, I think that particular analysis had about 80 people in 4 trials. It's a tiny data set. You've got to be really cautious about saying much about it. And what we then did, and this is something I want to come back to, we then made a recommendation for adult CBT to be offered to children over 15. Now, it's worth knowing that there, the effect size, a much larger set of trials, better conducted, consistent across the different models, whether it's the Clark and Wells model, whether it's the Heimberg model, whether it's Joe Bloggs' model. Again, the effect size is about 1.2. And that compares pretty well with many of the adult anxiety disorders. Some get a little bit higher, but it ain't bad. And it just, for me, the kind of point of putting that slide up is you spend a lot of time, I think, in the child mental health world developing general interventions for anxiety, and they haven't been very effective. And so one thing I want to come back to when we finish shortly, I finish with the main slides at least, is how much you think you need to be thinking about developing much more specific interventions. Because although this is it's weak data, you couldn't really say a great deal on it. We stretched it and produced a recommendation on that, and it was a stretch actually, we had a series of it. But it's something like 4 times, if that's a meaningful comparison, it's substantially greater than the non-specific treatments, but it's substantially smaller than what it looks like you can get in the adult world. And there is a question, come back to, how much can you extrapolate down? Now I just want to look at it a little bit more just to say, well, this is not all bad, but there's a rather extensive meta-analysis of about just short of 250 trials looking at social and emotional learning programs by Durlach et al. And there is evidence that those classroom-based interventions, both I think at the universal and selective program, do bring about improvements in social and emotional skills, do bring about improvements in behavioural problems, and are associated with improved academic achievement. But I don't know, Peter and I were involved with Richard Laird some time ago looking at a proposal that Richard had, and when we looked at the data, the effect sizes were not large, and there's some question about the durability, and I think there's still uncertainty, but nevertheless, it seems to me like there is something there. And how much is that really a focus of what child mental health services are doing? How much is that part of the life of the average school? And then just another one, just to say there's some value in it. This is by, it's a study, done a number of studies, it's a study by Judy Garbo, happens to be Steve Holland's wife, and features much in his lectures on the benefits or otherwise of SSRIs in terms of controlling the emotional tone of the average New York Jewish family. He's for it. He thinks it has a benefit, not on depression, but on general emotional tone. And what Garbo and colleagues did is that they looked at at-risk kids, and they defined at-risk kids as being kids whose parents had a depressive episode. And provided that Beardsley's done similar up in on the East Coast. This is, I think, origins are down in Tennessee, and they get a hazard ratio there of about, not of about, of 0.68. So again, some real indication of benefit. Now, what's the interesting stuff about this that you start to think about? So that looked well for at-risk of depression parents, i.e. had previous depressive episodes. If the parents were currently in a depressive episode, there was very little benefit associated with that treatment. We were looking last week in a group Peter and I are involved in, looking at internet-based treatment. So people familiar with New Gym, variants of that, Brave, or there's one called Camp It Up or something like that. I got it wrong, but it is Camp Clap a Lot. Anyway, there are a variety of interventions for kids, and what's quite interesting looking at them, and effect sizes are modest here, is the depression ones and the anxiety ones seem to do well for anxiety. And this is true in the adult world as well. Beating the Blues, who people might be familiar with, if you do we did a subgroup analysis of that, and curiously the group who didn't seem to benefit from Beating the Blues were the people who had straightforward depression. Those people who are depressed and anxious did quite well, and those people who are anxious did very well. And that seems to be replicated in Mood Gym, which is a web-based depression program adapted, I think, for kids as well as for adults. Why was that? Well, it's quite interesting when we looked at a subgroup analysis, and it seemed to us that there were a subgroup of depressed children who were harmed, who looked to do worse. And so it may be that the relative lack of effect for depression is that there are some kids who do badly and some kids who do well, and you see a much more effective result, whereas anxiety works out. But this is, I think, a 2-hour group for 8 weeks. And significant shifts, and the 9-month, 12-month follow-up looks like the effect size is maintained. So it's not all bleak, but the prevention stuff just isn't, I think, that well represented, and the data is a little uncertain. So what I want to do is just finish up with some questions, go back to those points I raised earlier, but also just want to finish with some questions which are really for you to think about. Where should the focus be in child mental health services? I'm arguing that you sort of folks should put me out of a job. That if you effectively treat childhood disorders better than you are, then I'm going to be seeing a lot less adults with problems. But should you be switching your focus much more onto prevention, as well as, of course, offering treatment? And what might be the barriers to doing that? Because, whether it's Sure Start, whether it's SEAL, whether it's, what is it called, PATH, one of the American programs, they've all had their difficulties in wider implementation. I didn't mention it, but we looked quite carefully at the David Old's nurse-family partnership stuff, you know that? Very much flavour of the month being rolled out in the country. We could see no benefit on antisocial behaviour in that one, despite the fact on the kids. And interestingly, Louise Howard, who's chairing our APMH group, has just done a meta-analysis looking at maternal outcomes, and she could see no benefit. And so I've got rather sceptical, really, of that programme, but it's, of course, you know, as you know, being widely rolled out. We probably need to, I'm going to want to go back to that data and look at it more carefully. How much is the internet, or more specifically the smartphone, going to be the way to deliver interventions to kids, indeed to adults? I think there's a real problem about case identification and recognition. I don't think you have in the CAMS world such well worked out systems. I don't think GPs are as wise to it, perhaps people working in schools. Social services certainly don't seem to be, from the contact we had on the recent guideline. But have you got effective tools? We struggle to find much beyond the SDQ that seemed to have the kind of sensitivity and specificity that you needed. How effective are the referral pathways in? So it's a bit the point you were making earlier about you can try and offer something, but if kids come through, they're certainly out there, that's for sure. And might it be about where you locate your services? Do we need to think wiser about how you do that? And then finally, how much do we need just very different models of, well, it's not five, I've got no set of slides, but you know, are our models, is it the diagnosis disorder-based stuff, does that get in the way, or do we need a different theoretical approach? In this case, what theories are going to help us with this? You know, can we break free of the stranglehold of attachment theory, which sometimes seems to me to kind of get a little in the way. Not that people here would let it do that, but it does seem often in conversations in clinical guideline groups, it kind of rather people run away with it. So how much do we need different models and different theories of childhood disorder? And then come back to this problem that emerged with conduct disorder and social anxiety disorder. I think conduct disorder is a real model of about how you go about providing effective childhood interventions. You know, it's based in really drawn a social learning theory. It has a theory of the development of the disorder. It's applied to the treatment. It locates that. It thinks carefully about how they might be developed. It takes not a systemic in the narrow view of that, but a systemic in a wider view of that, and looks at the role of parents, looks at the world in terms of parent training, looks at the world of school, of peer groups, of community settings in terms of MST and similar treatments. And is that the right way to be going, or is it that the multiple comorbidities of childhood and adolescence require that, don't allow that disorder-specific view to come through? All I'd say is that I think a disorder-specific approach in adult anxiety disorders has revolutionised outcomes in adult anxiety disorders. They're a lot better than when I was a kid. How much are you dealing with issues around parents? On our group, we looked quite carefully at work that Kathy Cresswell, this is social anxiety disorder I'm speaking about now, Kathy Cresswell and Sam Cartwright-Hatton had been doing, trying to involve parents in treatment. But actually, that data's not quite there yet. I mean, I know there's a strong view that that really is the thing to do, but actually, we just didn't have the data. Is that the right way to be going? It seems sort of obvious for younger children, but maybe it isn't. And the other question is, what about this recommendation we have in social anxiety disorder about adapting, whether it's Clark and Wells or Rick Heimberg's approach to individual treatment of social anxiety disorder? Should we just be taking those and adapting them, or not at all, for a 14, 15, 16-year-old? I mean, are you going to get just the same outcomes? A bit of evidence that doesn't quite work in depression. I don't, the Harrington and Goodyear trial, not very convincing really. So they're just questions I'd like to get your views on, folks, or indeed any other comments and questions that you have. So just to go back, what's the theoretical models we need to be basing this on? Are we identifying the right people? Do we need a disorder-specific approach? Is it parent-led? Is it the adjustment of adult interventions? And if maybe making any comments that you have, just think back to those issues we talked about, resource and the model. So that's me finished for now, but I would be very interested in whether I'm just being unkind to you and it's just that you haven't got data, or whether, as I might put it in a slightly more colloquial way, you know, child, adolescent mental health treatment research needs a kick up the bum. Which one is it? Any thoughts?
In terms of theories, and I think it depends a lot on professionals' background and where they are from. I mean, we are not talking about only the sort of clinical background, but also cultural background as well. One of the questions in my mind is how much you take into account, you know, cultural elements when you make recommendations. For example, the social phobia or social anxiety disorder. You know, in some countries, you know, being a member of a group is much more than it's just it's equal to life, you know, for example, and the approaches are different from my experience. And so it may be one of the interventions which work well in one country may not work well in another country. And I don't know, when you make recommendation, I think you get a lot of evidence from all of the world, possibly, and when you come to a point make a recommendation, you know, how much you just have to bear in mind that this is not.
Well, you do have to bear that in mind. That said, there's a number of responses to that. Actually, psychological interventions, in fact, I think transport pretty well. So, for example, there are studies of treatment of PTSD in Kenyan refugee camps. There are studies of the treatment of depression, IPT, in Uganda. There are studies of the benefits of step care CBT models in poor ghetto populations in Santiago. So I think they can translate. I think often the bigger problem actually is not so much cultural ones, there will be some, and I think that's, the data would suggest, that the data I know, that cultural competence is the way to address that, rather than sort of people are familiar with some of the issues. I've just spent a week in Korea, and you know, yeah.
I'm a Korean myself.
Oh right, yes. Well, that's probably what prompted it. I mean, bizarre the way they deliver. I mean, this is anecdotes on Korea. But we discovered, amongst other things, that there are still laws in Korea which say that if you have a mental disorder, you can't be a lawyer, a doctor, a cook, a sailor, or a hairdresser, and you can't walk in a national park. Which, when I think that Korea's national hobby is hiking. So, but also there's all sorts of it. I have to talk to you after, but it was very interesting. It was an interesting time. But I think you can do it. But I think often the bigger challenge is the difference in healthcare systems and insurance systems and how people access treatments. I think they're often as big a deal as the cultural ones. But you know, in a place like London, you've got big cultural issues. You know, issues about which are class and ethnicity based, about access to treatment. You know, are there a lot of kids from, there's differences on ethnicity in terms of presentations and prevalence of conduct disorder. There's certainly big differences in kids who come in and what kids experience of it. We talked to quite a few of them. But so culture's one. Any other thoughts? I mean, is there a crisis in treatment development in CAMS, or am I just stirring the pot? Go on.
I had a thought that I've had, but it's probably quite simplistic. I'm a speech and language therapist, so I'm kind of slightly out of your field, but we're also interested in like thinking about the effectiveness of approaches. But I think you talked a little bit about the problems in identifying children with these difficulties, and I've worked a lot in schools and I've worked in children's centres as well, and the kind of mental health is just doesn't really seem to be on the agenda or at the forefront of people's minds. It's not really discussed, and even when talking about children with known behaviour difficulties, I've never heard a child described as having a conduct disorder, even when talking about people who work in crews. So I think maybe some of it is also to do with that, the awareness and the identification. Like you said that, you know, about social anxiety disorder, the most common.
Or just behind depression in terms of presentation to child IAPT,
And you know, I must have met lots of children, because I work with autistic children as well. I must have met loads of children, but not to my knowledge. So I think
Well, we had a long debate with the Selective Mutism Association as to whether there is a subgroup of people, young children with selective mutism, have essentially got social anxiety disorder.
Yes.
And I think we're a bit unclear. Not my field, but that's certainly an issue. But I think there is massive under. Why do you think that is? Why is there this under recognition?
It's not taught about in the training programmes, and it's a prevalent attitude. What you were saying about schools was really interesting, because I've worked in schools too, and with children with autism in schools and mental health difficulties and all sorts. And even when children have a known diagnosis of, for example, autism, you'll often, and I'd say more often than not, encounter a teacher who's saying, oh, it's ridiculous, this mental health diagnosis, he's just naughty, he's just difficult, he hasn't got a problem, he doesn't need all this support and all this fuss, and it's bad parenting, and that's the kind of attitude. And I'm not trying to be down on teachers by saying this, it's just that they are clearly at some stage in their training, it's just missed out. They're just not taught to recognise these things or taught to be sensitive towards them.
I've got probably an even worse example of that, and I think they're not being aware, not being recognised. I was listening to BBC for Norfolk radio, and
you were desperate.
that was by accident. And the reporter was saying that there was I don't know, some guidance or some handbook developed by one of the organisations to help
kids with conduct disorder.
Yes.
Yeah, this was about probably about a bit less than a month ago. This was the launch of the conduct disorder guideline.
Right. Yes. So this guideline, and he was introducing this guideline, but he was saying to help to parents or teachers to recognise when a child is more than naughty. And he was saying that how he introduced it, it sounded like naughty equals ADHD equals attention deficit disorder equal conduct disorder.
Yeah.
And I just thought,
well, interesting. We had a very good launch of that. We had we got on Radio 4 Today programme. I did a couple of I did Daybreak TV sitting next to Lorraine, just having her hair done just before I talked. It was quite amusing. But I did several of these radio talking things, and I was really pleased that the kind of person, person running the show, even something like Tony Livesey, ex-editor of the Sunday People, were very thoughtful, very sensible. They got quite nice, thoughtful people to comment on it. They got parents that had nightmares with their kids, and I said very sensible things, and it was all jolly. And then the text came in, and they were like, it just needs a kick up the arse. I'd slapped him around the head, that was sorting that. And that is, it's a very strong attitude, really, that is difficult on conduct disorder, I think, to get round.
I felt that the reporter hadn't done his research or
Well, NICE produced very good press briefings. He or she probably hadn't read it, but they did a good. I think they do that very well. Actually, they do it very well. Anything else, folks? Any other comments or questions?
Just curious to know how you feel about giving children a diagnosis of conduct disorder when the successful interventions seem to be around the child, so the parents. And it's quite interesting that, just wondering, are there different maintaining factors in children compared to adults? So it could be, the reason conduct disorder interventions do so well is because they don't focus on the child, they focus on the surrounding.
Well, it depends which one you do. The child parenting stuff, I mean, there are, if you flip back to the slide, there are kind of 4 that we were recommending. There is the school-based ones, which are kind of classroom-focused, and they're about teaching the kids social, emotional skills. They look pretty good.
What are the effect sizes like?
The effect sizes of those are smaller. They're around the 0.3, 0.5 area. And some of the bigger universal ones, they get down to about 1.15. But then you're thinking, for some of those kids are making no difference. So that probably reflects that there is kids, and then it's a simple cost-effectiveness argument. And conduct disorder is so expensive that I think actually you can probably mount a cost-effectiveness argument for universal prevention. But certainly it's true that the parent training is very much focused on what the parents do. The group social one is kids focused. But MST I mean, although MST is all about, you know, increasing the capacity and the resource of the family to help manage the child, the focus is very much on the kid.
But it's still multi-systemic, so
it's still multi-systemic. Yeah, it is still multi-systemic. So, are you saying then that actually, to be a little provocative at the moment, that child mental health services haven't got much to learn from adult services in the disorder-specific way I'm arguing for? It's that multi-systemic stuff that's going to deliver.
Well, that's the question. I'm just curious to know if...
Yeah, I don't know the answer. Yeah. I hope you did. But
no. Well, I'm just fishing around for possible explanations. That was one I thought of. The other one I was thinking of was, I mean, it could be a developmental thing. So perhaps for things like CBT, you need to be just a bit further along in development.
I think that's right.
I was just curious to know, for instance, is there any evidence in adults that if you've got, I don't know, lower IQ or worse executive function, that you do worse with CBT? Because then you could maybe extrapolate from those results back to children and work out why the effect sizes aren't as good.
Yeah. I mean, well, it just raises a question about what is CBT suffers a bit from the fact that it's not one thing; it's a multitude of things. So, and indeed, most, I mean, so like for example, just flip to another area. My experience, I wouldn't claim any great experience in this area. You know, for example, the CBT treatment of OCD seems to me pretty largely about response prevention. You know, you just got to stop people doing it, and then the anxiety things disappear, and that's as effective with a 5-year-old, a 15-year-old, or a 55-year-old. I think really. So I think there may be different models, but that cognitive stuff, a sense of self, that you probably need to do some of the more higher order cognitive thinking associated with a class of treating depression. I'm sure you really do struggle until you get, well, it's a developmental rather than a chronological thing, but I'm sure that's a factor. But I think the point is not that you would adopt a purely cognitive model, it's just that there is this question about the model of development. Is the model of development that's been chosen in the adult world the right one? Because I don't know, Kathy Creswell, who, I've known for some years, she's very much a cognitive behavioural therapist, and they've developed that model, and, Kathy's quite sensible and thoughtful about all this. I think their effects are, sort of modest, really, but they're developing. But you can do it. There's some view I think you are starting to talk about.
Yeah, that's what I was just
parental involvement in anxiety disorders may be the way to treat it. But again, Kathy and Sam's stuff, it's
interesting though what you said before about you mentioned young people who are at risk for depression because they had parents who were at risk for depression, and in the at risk for depression parents group the therapy was effective, but in the group whose parents were in a current depressive episode it was less effective. And I think that was the point that I was trying to make, and it goes back to what Andy was saying about maintaining factors, because I think some of the stuff that Kathy's looked at, not necessarily herself but some reviews of theirs that I've read, is more that when you might have a good effect of a CBT treatment, whether the parent's involved or not, in a child initially, but it's not maintained because part of what's going on then, it goes to the kind of system around the child, because the parents are helping them to maintain their anxious behaviours, perhaps, and so the maintenance of recovery is not
you see that in adult depression.
Perhaps.
So for example, relationship difficulties are predictive of poorer response to CBT in depression, and they are predictive of a higher rate of relapse in depression. So behavioural couples therapy, which is one of the ones that I had at the top, a lot of that is about, it's essentially a Neil Jacobson invention of 30 years ago, and it's got a bit more communication focus, but it is about focusing on the relationship, and the results look pretty impressive.
Okay,
really. So I mean, there is, again, that's why CBT isn't kind of one thing. I mean, would I call it? People call it behavioural couples therapy because Jacobson was a radical behaviourist, but you'd struggle to distinguish that much from what a CBT practitioner would do. At least I think you would. I think it's a heartfelt plea, this, folks. I really do think we've kind of got to up the game on child interventions, because it's so important in changing people's lives. It's a real it is a real challenge that you know, Anna Freud and one or two other places around the country should have a go at.